Okay, Tara, all you.
Good evening. My name is Tara Glazer, and I am the Assistant Program Coordinator for our CSS program, which is the Community Support Services Program. We are a residential program here at CBH Care, and our consumers all live independently in the community, and we have case managers and clinicians like myself and my co-coordinator who go out with our case managers as well and offer support to our consumers in the community. Our consumers all have severe and persistent mental health issues, which is basically what we're going to cover tonight. Those type of diagnoses and the symptoms related to those diagnoses. I have an LSW. I have worked for the agency for 12 years. So I have a lot of experience just working with our population and with different resources within Bergen County. Okay, so first we're going to talk about bipolar disorder. I'm sure everyone has heard of bipolar disorder. Some people refer to it as manic depressive disorder. That's a lot of an older term, but bipolar disorder is a variety of symptoms. Sometimes I refer to it as the roller coaster mood. So some consumers can experience the up and down mood. So the up is mania. Mania looks like a long period of feeling high and up, and you feel euphoric, and you can conquer the world and nothing's going to stop you. But it also can look like irritability and extreme irritability that some people don't even recognize, could be related to their symptoms. Some people who are manic or experiencing mania can talk very fast. We refer to that as rapid speech. Sometimes the speech is pressured, which means someone could be just talking, and you can't get a word in edgewise. Some people also will experience tangential speech, which means they might go on a tangent and be talking about something that has nothing to do with what you originally were talking about. They also might be experiencing something like racing thoughts. Can't shut your mind off. Another reference I sometimes use is the hamster on the wheel. Your thoughts are just going and going and going, but sometimes they don't make any sense. And it could be just word salad and thoughts that are not connected, which can be very frustrating. Some people might increase their activities, start something, never complete it.
It's on. I mean, I can see her. I can't hear it. No.
Okay. Oh, sorry. Okay. Some people also might be restless, pacing, not able to sit still, not able to feel that sense of ease and relaxation. Having sometimes some grandiose thoughts, thinking, I can conquer the world. I might not have a degree in astrophysics, but I'm going to go and I'm going to fly to space, and I'm going to fly that spaceship because I can do it. So that's something that might happen too. I've heard a lot of people in a manic state wanting to invest in a business. They have $10,000 that they've saved, and they're going to invest in this business, and they're going to become so successful and have all of these ideas of how they're going to succeed. But then unfortunately, the investment really doesn't have much of a plan. And sometimes they can be, put in a situation where they're financially strapped. And then this also, impulsivity can be risky in many ways, because some people engage in substance abuse behaviors, and sometimes when you're under the influence of drugs or alcohol, you can engage in hypersexual behaviors, and it's not always the safest behaviors. So when someone is in a manic state, they are putting themselves at a high risk when they are not on medication. Unfortunately, this can also affect job performance. If you're out and not sleeping and engaging in risky behaviors, you might not be waking up for work. Or if you're over irritable, and you might not be able to get along with your coworkers. So sometimes we're seeing people who are often losing jobs, getting a job, not able to keep it, which can be a very big struggle for people, especially in a world where you need money to function and pay your rent and buy your necessities. There's also a depression aspect with bipolar. So we go from very, very high up and sometimes after being manic for an extended amount of time, a person might call what we call the crash. So then it goes down to the depression. And the depression can just be feeling sad, hopeless, no motivation, no interest in activities you once enjoyed. Also, maybe no motivation to go to work, no motivation to get up and do anything. It could be not wanting to shower, not wanting to make dinner, not wanting to clean your house. Sometimes maybe not being able to, if you can't take care of yourself, not take care of your family, which can be very hard. But then you could also be restless and irritable because you're just not feeling like yourself. You're not feeling good. You could have concentration issues again. The racing thoughts, probably not so much, but you just might not be able to focus. You might not be able to start a task and complete it in the sense of the motivation isn't there because you're just down. Some people, unfortunately, also change their habits when it comes to feeling depressed. When the bipolar is in, you just might not want to do your day-to-day stuff. Some people might stay in bed for days at a time and not even realize the time is passing. And also with bipolar, there are symptoms sometimes of suicidal ideation. And, that is a risk when we are talking about suicidal thoughts. We want to always make sure we're talking to someone and making sure they are safe. So safety planning is a big role for clinicians and for individuals who are working in the field and working with individuals with mental illness. But a positive with bipolar, not that anyone wants to have to deal with these symptoms, but there are medications, there are treatments, and people who are in treatment and who are taking their medications the way that they should can continue to function on a daily basis and can hold a job and can move forward in life. They don't have to be stuck. They don't have to be disabled. Unfortunately, some people, their symptoms are so severe that they are unable to work. They're unable to hold down a job. But that's why there are benefits for individuals with mental health issues where they can apply and hopefully get the financial support. Do we have any questions about bipolar disorder?
So if they don't take medicine, they have stopped their medicine, they don't think anything is wrong, what do you do in that case?
So unfortunately, I think with mental health issues overall, a lot of people struggle to recognize that the treatment is helpful. A lot of the first step is acknowledging that you need the help and accepting the help. There's a lot of people that struggle with being compliant with medication. I've seen people struggle with many years. I've known people who've been in treatment for 30 years, and unfortunately they struggle with accepting that the medications are actually helping. And, the benefit is having a good relationship with your psychiatrist or psychiatric APN, also having a good relationship with your counselor, case manager, therapist. And for a family member, I know it's difficult because you can't make that person take the meds, and you're the one that's seeing them struggle. And so, I always say the best benefit is trying to get them to talk to someone who's a professional who is willing to do that, that psychoeducation, because it's so easy to start meds. I've seen so many people say, okay, I'll start the meds. And then all of a sudden they're like, I feel great. I don't need them. I'm going to stop them. And they feel great because they're on the meds, right? Or maybe someone's feeling better because they're in therapy. And a lot of times people will say, oh, I don't need this. I'm good. So it's a lot of psychoeducation, I think, and med education on the psychiatrist's part. And I know Jenna said that they're going to have a prescriber talk about medications and how the medications work. And I do think that people who are on these medications deserve to understand what they're doing, what the chemical is actually doing to help stabilize their mood. And unfortunately, some people really enjoy being manic. Some people don't always see the negative, and some people will say, well, listen, I'm getting up, I'm going to work, I can do all the things I need to do. they don't realize that maybe it's taking a toll on their life, or maybe their relationships with their family and their partners is difficult, or they can't get along with anyone at work, and they're not recognizing that this could be related to their mental health issues. So it really does take a lot of time to explain to the individual. And, you know, it's not always easy, because I know some people get very frustrated and don't want to hear it.
Right. Right.
So-
I know that. Right. It's very hard if somebody doesn't want to take it, and you're trying, and, you know, they stop, and just, what can you do? I mean, what could you do? I don't know. And smoking weed doesn't help either.
Well, and that's, you know, the substances are a hard thing when it comes to mental health issues, because I always say, how do you know if the medications are working effectively if you're using a mind-altering substance? And we don't, right? And a lot of doctors, a lot of clinicians will say, you really shouldn't mix, because
Right.
it's not beneficial. And just because alcohol is legal, just because marijuana is now legal, doesn't mean it's beneficial. They're finding different things and different positives about marijuana, but, you know, the psychotropic medications have been around and effective for a long time, and there's so many different stages and levels of them that people for years have been able to say, listen, they've changed my life. This, you know, has helped. But a lot of people also are abusing the substance when they have a mental health issue, because it's probably helping not have to focus on the mental health issue too.
Exactly. So if they don't go back on medicine and they stopped it, does it get worse?
I mean, I don't know scientifically that exact answer. I mean, I'm sure it's not helping, because, you know, something like marijuana can increase paranoia, can increase hallucinations. And when people are experiencing symptoms of bipolar, there is a component where some people do experience psychosis, which could be paranoia, hallucinations, whether it's visual, audible, tactile. There's so many different olfactory.
What about voices too? They hear voices.
Yeah, people who are experiencing bipolar symptoms could experience psychosis, and auditory hallucinations are a symptom of psychosis. And that's where I feel like it's a hard line. And I think a lot of doctors probably are unsure too, because is the marijuana helping? Is it increasing your symptoms? It's very hard to tell.
Yeah. Yeah. Okay.
Do we have any other questions about bipolar disorder specifically?
I think I did everything. I'm good. Thank you.
So maybe we will move into depression. How's that? Okay. So with bipolar, you know, I did start talking about depression and explaining depression. It's interesting, because I feel like with bipolar, depression, and schizophrenia, sometimes the symptoms of each diagnosis can come into, you'll see different symptoms coming through that can also be part of another diagnosis with those three specifically. So we'll talk about depression and that now. It's one of the most common mental health disorders in the United States. I don't know how accurate this statistic is, but it was saying women are 70% more likely than men to experience depression. Everyone occasionally feels sad and blue, but depression is a different type of sad and blue. I would say, you know, when you're not feeling happy, or you're having a moment where you're feeling sad, that will last for a short amount of time, whereas depression interferes with your daily life. It causes pain for you. It affects your daily functioning. You know, some people don't have the motivation to get up. Some people are just physically exhausted. So not only is there emotional exhaustion, but sometimes depression can cause some physical exhaustion and difficulty getting out of bed, difficulty completing your activities of daily living, showering, brushing your teeth, eating properly, doing your daily things like laundry or going to work. These things are all activities that you might not care about if you're experiencing symptoms of heightened depression. And, you know, people with depression might not realize they're depressed. So that's hard too. You know, a family member might see it, a friend might see it, but they might not realize. There's irritability. There's sometimes with the irritability, maybe some explosiveness, but, you know, hopelessness. And again, unfortunately with hopelessness, sometimes that will lead to suicidal ideation. And we want to be careful. You want to make sure that if someone is threatening to hurt themselves or someone else, that we take it seriously and, you know, make sure that they get the proper help and the proper support, because it is not our job as a family friend to judge whether someone is being serious or if they're, you know, maybe just having a moment, because unfortunately, sometimes people do follow through and then there's nothing we can do. Depression, usually with major depression, an episode can occur only once in a person's life, but more often a person will have several episodes in their life. And that is a diagnosis where medication is very helpful. There are people who suffer from depression, and medication and therapy are very helpful in getting a person to function and be able to complete their day-to-day stuff, go to work, enjoy life. Yes, if someone is depressed, they might experience sadness, but it might just be natural sadness from an event. It might not be that hopelessness and that doom and gloom and that real negative mindset. So people can function. It's just a matter of getting the right help. You know, with depression, psychosis can be present as well. So if a person has severe symptoms of depression, they can also develop some paranoia, some delusions, hallucinations as well. And, you know, again, there are different medications that can stabilize the mood and can help overall, again, with the psychosis. Postpartum depression is something that I think has become more of an open topic. I think back in the day, you know, it was the baby blues, and a lot of doctors would just say, okay, well, this is how you get rid of it, is just get pregnant again. And it was because the hormones were imbalanced, but no one really thought that was, now that's not the answer. Now they're asking the questions very early on, and, you know, women are experiencing this hormonal and physical change. The hormones drop, and it's a severe thing, and women are more open about it. We have a program at our agency in our outpatient department for postpartum depression. I think we still have it. Yeah. So they say an estimate of 10 to 15% of women experience postpartum depression after giving birth. So I think the more we talk about it, the more open people will feel and the more options there are. Medications, psychotherapies, any type of treatment that would help depression is the best help that someone can get, because dealing with it on your own is very isolating. And unfortunately, after a year like we've had with COVID-19, isolation has become much worse. You know, people who might not have noticed any mental health issues prior, you know, I think this has made them worse, you know, or they've noticed things more than they ever did because we had to stay home. We had to isolate. We had no choice. And, you know, it can be very hard on someone to not feel that you can go and interact. Human interaction is a big thing. So if someone is isolating, that takes another toll on them, not being able to interact with others. There's people who, I don't know if you've heard of this, people experience the seasonal affective disorder. Some people will say, oh, in the winter, like, you know, some people have just taken mental health diagnoses and just freely throw them out. But there is an actual thing where people in the winter and when it gets darker sooner do experience the seasonal changes, and it can really affect their mood. I've heard of people buying lamps that kind of are sun lamps in a way, and the brightness can really change the mood and the overall impact that the season could be having on someone. But that's actually something that is a real diagnosis. It's not just something that is thrown around. But, you know, that feeling of emptiness and hopelessness and symptom of depression is something that's real and something that people are experiencing every day. And more people are talking about it. Anyone have any questions about depression?
Roberta, you are muted. You have to unmute yourself.
Sorry. When you talk about people being sad as opposed to being depressed, is there a length of time that the sadness continues to become depression, or?
Yes. I don't have my DSM with me, but someone who has major depression, it's lasting for, you know, an extended amount of time. With persistent depressive disorder, the depressed mood lasts for at least 2 years. So there's also sadness, there's grief disorders. So these are newer to this recent DSM, which is our diagnostic code that we use when we're diagnosing someone. If someone lost someone and they're grieving, they might, you know, I don't put a label or a time frame on grief, but then with these grieving disorders, they're saying, well, if the grief is affecting you for a year and you're still unable to function, you're not able to get up and do your day-to-day stuff because you're still so, you know, distraught from the loss, then it might be an unresolved grief, right? But with depression, if you're having these episodes, and again, the symptoms must last for 2 years, then that's not sad, right? That's not having a bad day. I think we can all agree we've had a bad day at least once in our life, right? At least, right. I mean, especially this past year, right? COVID has challenged us all, and I think has challenged all of our patients and our mental health too, right? But when it comes to depression, the symptoms have to be present for an extended amount of time. They have to be, you know, at least, I believe it's at least 6 months, and then they have to revisit it. So when someone comes in, I remember when I was working at our wellness center in Westwood, when someone would come in, we would ask them, how long were the symptoms, right? Because then that's how we can determine what we're looking at. If someone's saying, I've been depressed my entire life, we're like, okay, this might be major depression, right? This is something that you've experienced most of your life. There also are situations where people have situational depression. Something happened, there's a loss. There was a traumatic event in their life that is causing this depression and the symptoms that they're experiencing. So this might not be something that's going to be major. This might be something that could just be situational. And with treatment, with medication, maybe they'll be able to overcome it, and maybe they won't need medication for the rest of their life. There are some people who've had it their entire life, and I always say there's that chemical imbalance, right? Like they're just not able to shake it. They're not able to find the positive. They're not able to find the hopeful because there's that negative loom of the symptom. And, you know, also with depression, it can affect your concentration. It can, and similar to other diagnoses, it can affect the way you're able to focus. Some people might say, oh, I've never really had motivation in school. I never really wanted to do anything. I never really enjoyed doing anything. These are all symptoms that we're like, oh, okay, we're gathering your information of what you've experienced over time. So it really depends on how long your symptoms have been present. But if you're having a bad day or a bad week, but you can relate it to a situation, I don't think it's depression. It has to be, you know, we have to have a time frame. And sometimes we'll also say, okay, something's going on, but we have to just explore it a little bit more and figure out, you know, is this depression? Is this something that's just situational?
So if you have somebody that you're worried about that has bipolar,
Mm-hmm.
and you're the parent,
Mm-hmm.
and you've been doing it for a long time, it gets very depressing.
Mm-hmm.
So, you know, you want to maybe take medicine, but then does that just Band-Aid it? Because the person still has bipolar and, you know, you're still depressed. So it's like, it's a no-win situation. That's how sometimes I feel, but I don't know.
Well, that's when I think that, you know, the support through IFSS and even a private therapist, someone that, you know, you can see one-on-one is beneficial as well, because sometimes as a caretaker, it's very draining, especially if the person is not open to treatment or they want to do treatment their way, right? Everyone's suggesting, oh, here are all these great options, but maybe they'll say, no, I'm just going to do this. And you know, they need more. But unfortunately, that's what happens a lot of times. But, you know, self-care goes a long way. And definitely for caretakers and family members, I'm a big believer that you have to take care of yourself too. And I know some people do wonder, are medications a Band-Aid? Again, the prescriber will talk more about medications, but I think the whole package is actually beneficial for any mental health treatment. I think that, you know, medication are great, but I also think the component of therapy or some type of therapeutic support is also beneficial. Because if you don't get your thoughts out, then they're just going to go and they're going to play and they're going to keep going. And sometimes people like to journal and get their thoughts out. But I also think, you know, therapy, group therapy, support groups, educational workshops, anything that is going to work is helpful.
Okay.
Hi, I have my hand up if you have a moment. Concerning paranoia, you mentioned it twice with the bipolar, and it could also present itself in depression.
Yes.
Are you referring to paranoia in terms of the psychosis, or because I always thought paranoia was part of schizophrenia? And I'd also like to know the breakdown of like a schizoaffective disorder diagnosis. Isn't that like a combination of schizophrenia and bipolar?
Yep. And I can go into that once we're done with this. I was going to go into actually schizophrenia next and then schizoaffective, but I could do schizoaffective, then schizophrenia. It's fine.
But as far as the paranoia, I'm sorry, so I jumped. The paranoia component, I guess it's just, it's all, it can be in every instance.
Well, okay. So with bipolar and the paranoia, psychosis can be a symptom. There are times that I've seen consumers who are not sleeping. They're in a manic state and they're up for days at a time. And our bodies need sleep. Our bodies need rest. Our mind needs to rest. And psychosis then can also be something that we've noticed. But there's also people who have those symptoms. That's just something that they've been diagnosed with. The psychosis can be there. And the psychosis can also be there, you know, with depression. You can have a diagnosis of depression with psychotic symptoms.
So psychosis, I'm sorry. So paranoia is an attribute of psychosis.
Yes. Paranoia.
Great. Okay.
Yep. Paranoia is a side effect, a symptom of psychosis. Yep. So, yeah, psychosis can intertwine in a bunch of different diagnoses, which I don't think a lot of people realized. You know, I don't think we really ever knew until we started to dissect the diagnosis. And, you know, unfortunately, sometimes when you have the swings of insomnia or, you know, just nonstop sleep, the brain, the body, things are getting, you know, messed up, unfortunately. But yeah, we've seen different symptoms with different diagnoses. It's not like, I know a lot of people have thought schizophrenia and schizoaffective disorder, that's when someone's experiencing paranoia, hallucinations, delusional thought process, and that's it. But we've seen it in other assets. And also even sometimes with anxiety disorders, because some people might be experiencing anxiety and it could be related to substance-induced anxiety. And sometimes some substances can make people experience psychotic symptoms. So yeah, we're learning a lot as, you know, we work with people.
What is the blank stare? Did you ever hear anybody say that they just look at you with like a blank? What is that? What is that?
What do you mean? Like what
if
is-
someone said, I guess that they have bipolar or something, when you look at them, it's like it's just blank. Like they don't have any, their
like
eyes are just.
like a
like a what?
catatonic kind of look,
Yeah,
like out of it.
yeah.
So in a moment like that, someone could be responding to internal stimuli. What do I mean when I say that? They could be hearing voices. They could be having visual hallucinations. Their thought could be blank. They could be just having blank thought process too. Some people, unfortunately, also might have a flat affect just in general, which is they're just very like blah and might just be in a daze. Some of the medications have caused side effects. I think it just also depends, one thing I always tell staff that I'm training is not every person has the same symptoms. And just because one person has, just because say two people have the same diagnosis, doesn't mean they have the same symptoms, does not mean they will benefit from the same treatment. Everyone has their own, experience with mental health issues.
Yeah.
Should we go into schizoaffective?
Yes, please.
Okay. Let me just.
Schizophrenia tower first, and then.
I'm sorry.
Start with schizophrenia first, and then the combination.
Okay. Yes. Okay. Sounds good. Let me find my notes. Okay. I was in order. Okay. Let me organize my notes so that we can. Okay. So schizophrenia is one of our chronic mental health issues, and it interferes with a person's ability to think clearly, manage their emotions, make decisions, and relate to others. It's a long-term mental illness, and it can happen at any age. They talk about psychotic break. They talk about when someone is getting their mental illness break. Sometimes they happen at the ages that they're discussing, but I don't know. So I don't want to give an age because children can be diagnosed with schizophrenia, but a lot of times you're going to see it in young adulthood in the 20s. And it, sometimes can be triggered by substance abuse, and sometimes it just happens. It's not as common of a mental health disorder as people think, but the symptoms can be very disabling. The symptoms of schizophrenia fall in 3 different categories. So positive, negative, and cognitive. Positive symptoms aren't positive in a good way. They're psychotic behaviors that are not generally seen in healthy people or people who are not experiencing symptoms. They are experiencing the hallucination. So hearing voices, seeing things. So that's auditory is hearing voices, visual hallucinations is seeing things. Olfactory hallucinations, that is when someone is smelling something that might not be there. Tactile hallucinations is when someone might feel something. Some people might say they feel bugs crawling on their skin. I would say the most common ones I see are auditory and visual. Some people have delusional thought processes. They might think that the president has, requested them to be here, and, they really believe that the president wanted them to be here to help them with something, and that's their job and that's their role. Thought disorders, unusual thought processes or ways of thinking, and that can be the paranoia, people feeling that others are out to get them, or worried to use the phone because maybe someone's listening in, or the radio's listening to them talk, or the TV's listening to them talk. Movement disorders like agitated body movements sometimes can happen but that you can see sometimes as a side effect to certain antipsychotic medications, excuse me, that the doctors will probably discuss. Some of the negative symptoms, they disrupt like normal emotions and behaviors. So the flat affect that I was talking about, so it's like reduced expression of emotions or facial expressions or tone of voice. So someone just might be like talking, you know, very monotone or just looking at you with that blank stare. Reduced feelings of pleasure in everyday life. So something funny might happen, but someone who's experiencing that symptom might not laugh because they're not able to recognize that something funny happened. Difficulty beginning and continuing activities. So maybe they started to clean, but then they swept the floor, but then they left the pile on the floor and forgot to put it in the garbage. So they might have gotten distracted and just didn't follow through. And sometimes people do sit and don't speak. They just might sit in silence. And that could also be that they're experiencing auditory hallucinations or their thoughts are just, you know, jumbled. Then there's cognitive symptoms. They're more severe. Patients might notice changes in their memory or other aspects of thinking. So the ability to understand information and to use it to make decisions. Something that I often discuss is when we talk to one of our clients, and they might not understand what we said, but we might have thought we were clear. So it's always helpful to maybe ask them to repeat it back or say, you know, what to discuss, what's the plan? You know, it might be, okay, I'm going to pick you up tomorrow so you can go see your doctor at 12. They might not have got all that information. So a lot of times I think leaving notes is helpful too, because they could have been distracted in the moment or could get distracted as the day goes on and not remember. So leaving notes to help, because sometimes the focus is not always there either, and it's difficult to pay attention. And ability to retain the information immediately might not be there either. And they might remember they had to do something the next day, but they might not remember what. So, you know, using aids to help our clients so that they can be more independent too and remember that they had an appointment the next day, because sometimes these symptoms do affect daily life and it's a matter of helping them through daily life. So again, medications are a big component, and case management. You'll see a lot of case management approaches with someone who's experiencing schizophrenia so that they can help with their day-to-day stuff, filling out paperwork, keeping their housing, paying their rent, making sure they're going food shopping, cleaning their apartments, just your day-to-day activities that they might not prioritize because they might not realize the importance of it. So some of the causes of schizophrenia, sometimes they say schizophrenia and schizoaffective disorder can run in families. So now I'm going to switch over to schizoaffective disorder.
Yeah.
So then we can kind of tie them both together. And if there's questions, we can do both of them. Is that okay?
Perfect.
Okay. So again, schizoaffective disorder, people might experience hallucinations, delusions. So the false fixed beliefs that are not real, disorganized thinking. So these are all symptoms that I already discussed with schizophrenia, right? But then we're going to add in the mood. So depressed mood can be present. So if a person has been diagnosed with schizoaffective disorder, depressive type, they will experience feelings of sadness, emptiness, feelings of worthlessness, or other symptoms of depression. So the symptoms we discussed of depression will be involved in this diagnosis in addition to the schizophrenia symptoms. So it's kind of a double diagnosis in a way. But they might not be depressed. They might be experiencing a different mood, which could be the mania, which we also discussed with bipolar. So here we're bringing in another diagnosis that we already discussed. And with the mania, the person Will experience the feelings of euphoria, feeling up, the racing thoughts, their increase in risky behaviors, and the other symptoms that we had discussed with mania. So when someone is diagnosed with schizoaffective disorder, we're treating now 2 diagnoses, if you think about it, because you want to stabilize the mood, so the depression or the mania, or sometimes it's mixed and they might be experiencing both. And you also want to stabilize the psychotic symptoms from the schizophrenia. So that's when they can come together. Oh, is she trying to talk? No.
You have to unmute, Caroline. Just, it's okay.
Keep going. Okay. So both of those diagnoses, if you have schizoaffective disorder, you have the schizophrenia and you either have the depression or you have the bipolar disorder. They're happening at the same time and they're present at the same time. Delusions or hallucinations for 2 or more weeks in the absence of major mood episode kind of is part of this. It can be difficult to diagnose because it has symptoms of the both schizophrenia and either depression or bipolar. So it's a matter of figuring out, you know, again, with our DSM code diagnosis book, you know, what's going on, and also the history. And I'm a firm believer of, let's see what helps. Let's see what treats, whether, you know, medications, you're talking with the doctors, what medications and which treatment. Like, we don't need to always throw a diagnosis. Unfortunately, that's a big thing for insurance companies too. But I think the most important thing is finding the treatment that works over finding a diagnosis. Sometimes, again, with schizophrenia and schizoaffective disorder, you might find abuse of substances and alcohol and drugs, which can then be a little difficult as well too, because it's hard to see what you're treating. Are you treating symptoms of, you know, a mental health disorder that's been there? Are you treating a mental health disorder that was triggered on by substances? Are you treating symptoms that are mostly substance use based? It's, you know, it's a lot of it is figuring out what is going on and what the treatment is. With schizoaffective disorder, you know, mood stabilizers and antipsychotic medications and antidepressants are often in the mix. And they highly recommend, you know, psychotherapy, case management if necessary, and, you know, utilizing coping techniques to help manage those symptoms.
So I have a question.
Yeah.
So if it's not hereditary
Mm-hmm.
and all of a sudden it just comes on when they're, say, 16 to 17, what happened? Did something happen in the brain? Like, what exactly? I know you don't know pinpoint, but what happened?
So they do say genetic can be a key component, right? But it doesn't mean a relative has the illness or will absolutely get it. Like, if someone has this diagnosis, it doesn't mean it's definitely going to be passed on. It means there could be a greater chance. If there is no family, stressful events such as a death in the family and end of a marriage or loss of a job can trigger symptoms of an illness. Brain chemistry, the brain function and structure might be different in ways. And like brain scans might show it, but I don't know much about that. Again, substance use can trigger things. Substance use, I've noticed throughout my just treatment, being in the field, is a big component of a lot of mental health issues. It, you know, I've seen a lot of young people come in and they were like, I was fine. Who knows if they were fully? They could have been ignoring symptoms that were there. But drugs and alcohol can be a big trigger to onset of mental health issues.
And that trigger could last, once that trigger is there, once it starts, it's there. Like, it can't, it just, I don't know, it feels like it's a lifetime. It's a long time.
So you know, some people will say, can I be cured? Can I fix, you know, am I going to be able to like not have this diagnosis for the rest of your life, of my life? I don't like the term cured. I think managing the mental illness is more effective and more helpful of an approach for clients to hear, because, you know, just like I always compare it to high blood pressure. Maybe if you change your diet, you'll completely get rid of the high blood pressure. But most of the time, people have to take medication to stabilize it and to manage it, right? So I kind of say mental health issues are very similar. If you take your medications or you go through treatment and you use your treatment, that can help manage your symptoms, and you can still focus and function and do your life stuff as much as you want. Unfortunately, it's not easy for everyone. Some people have more chronic symptoms than others, and some people, you know, their day-to-day life is not going to be as active as others. I think everyone is just different. And again, you know, some people might have a diagnosis and another person might have that same diagnosis, but treatment is completely different. Their symptoms are completely different. And that's just how it is. It doesn't, you know, mental health doesn't just go for one type of person. You know, anyone can get these symptoms, and you see it across the board, different socioeconomic groups, different cultural backgrounds, different races, different genders. It doesn't, you know, specify to one group of people.
Yeah.
Tara?
Yes?
Yeah, I have a couple of things. I've been a NAMI family to family presenter for over 4 years. And there's a couple of things that I've learned differently than what you've laid out.
Okay.
And so I kind of want to, like, you know, discuss it a little bit to see what your take is, or other people who have some experience.
Yeah.
Number one, it's my understanding that things like schizophrenia and bipolar specifically do have a genetic component, which does not mean that anybody in the family will get it. It just means it's in the genes.
Yes.
Right?
Yep.
So in my situation, my uncle, my great uncle both had bipolar, we believe, because back then they didn't really diagnose clearly, right? But we believe, and then it skipped a generation. Nobody in my generation had bipolar or anything, although I was actually diagnosed borderline bipolar at one point in time in my life. And I do have some of the symptoms, ADHD, and fidgeting and inability to, you know, keep several of the outlying symptoms, right? And then it shows up in the next generation that I'm not going to speak to specifically, but my loved one is in the next generation, and they live in Bergen County, so I don't want to, like, you know,
no, that's fair. Yeah.
right. So I don't want to go into who it is, but anyway, so we've definitely, you know, seen the genetic strain. So I don't want to just tell people it's not genetic. I want to say, you know, there's a good chance that there's a genetic component. We're just not clear on what that is and how it's manifested, right?
Right.
The second thing is that I've always understood schizophrenia to be a thought disorder, and bipolar and depression to be mood disorders. Okay. And I've understood from someone who has schizoaffective that schizoaffective is actually either bipolar or depression with psychosis outside of the episodes, outside of the episode. So if somebody has psychosis when they have mania or depression, that would be the mania, or that would be bipolar or depression with psychotic features. But if they have it and they're not manic and they're not depressed and they still have psychosis, then that would become schizoaffective. That's what I've understood.
So if they don't have a mood disorder, if there's no mania or depression, but they have the psychosis, I would say schizophrenia. No, I'm saying if they're stable. They've already been diagnosed with bipolar. They've been diagnosed with depression, right? But they're stable. They're not in a mood swing. Okay, yeah.
Right, they're stable. And then they have some kind of psychosis, like lack of insight, or thinking that they can make $1 million in a year's time by investing $500 on by day trading, which is my loved one's wonderful delusion that they can't let go of no matter what we do.
Well, that could also be a grandiose symptom too, which is also a big symptom of bipolar disorder. And, you know, the mood might be stable. They might not be having a swing or the roller coaster, but unfortunately, sometimes some of the symptoms are still present, right? And that grandiose thought process is a very common symptom with bipolar disorder.
Right.
You know, I mean, I wish we could all win money. I make money on the stock trading, like that mindset, right? Would be great. But yeah, I think a lot of people do have the stability. So maybe the extreme symptoms aren't present because they're more stable with the medications, but sometimes the symptoms do come and go.
Yeah, he's not taking medication.
Okay. Yeah, I've also
that's another issue, is that we can't get, you know, the right medications, and we can't get them to take medications because of the side effects, basically.
Yeah. Well, and I've seen people not on medication and doing all right, but could they be doing better? Sure. Right. And I think that's the hard part with people too. Taking the medication can completely level out that mood. And again, some people really enjoy the thoughts and the, you know, ability to be able to do everything that mania can bring, right? And if they're not doing anything that's completely harmful, I think then you'll see someone say, well, I don't need the meds, I'm fine, you know, I'm functioning, it's nothing too extreme. And a lot of people might say, well, I haven't been in the hospital, you know, there's always a reason, you know, to validate why medication isn't needed. But going back to your genetic thing, I think genetics, you know, with research, genetics can be a big component to diagnosis. And as you said, you've had experience with it, you know, skipping generations. But I think, you know, what research is saying is that it's not only just genetics, because, you know, you know what I mean? It's not only genetics, and there could be other components that do trigger the diagnosis. And, you know, life experiences and environment are a huge thing. They've done, you know, studies where it's like, I mean, it's so inappropriate. They've separated twins, and like, then they've studied one living in a great environment and one living in not so great an environment, and seeing the changes. And, you know, it does happen. Or even someone who might have been genetically, you know, exposed to a diagnosis, but maybe the life stressors weren't so bad, so the triggers weren't bad. And when I say triggers are the life stressors or the life experiences that could be the, you know, what is the onset to these illnesses.
Well, the onset, and also if they're not medicated, it can cause it to escalate.
Yeah.
And get worse over time. And that's what's happened in our case.
Yeah. And that's and unfortunately, different things become triggers over time too, right? So what might have started as a trigger, say in their teens or their 20s, might be nothing compared to what they're dealing with in their 40s or 50s. So, you know, there's a lot of components to these mental health issues. Yes, genetics are a big thing, but also we're seeing just a lot of environmental stuff too, you know. And when you had mentioned with the bipolar symptoms that ADHD can be something, I actually had been seeing that more and more. Young adults coming in saying, I was diagnosed with ADHD as a kid, you know, and what we're seeing is, did that child have ADHD, or were those early onset symptoms of bipolar disorder? And, you know, the psychiatrists do not like diagnosing children with these major disorders and disabilities, because you're putting a label. And we all know the stigma, even though we really want this stigma to be gone, it's there. And we're working our hardest to get, you know, that stigma free, you know, vibe out and everywhere because, as I said, it doesn't discriminate. Mental illness doesn't discriminate. Anyone can come across it. But a lot of psychiatrists don't really like diagnosing kids who might have symptoms of bipolar at a young age. So then I've seen, you know, young adults coming in saying I was diagnosed with ADHD. But now I'm noticing different symptoms, and it could have also evolved with age too for them. Age, life stressors, you know, environment, all of that. Or it could have also been bipolar when they were little and it just wasn't diagnosed and wasn't medicated.
Yeah. One other quick thing, and then I'm going to stop.
That's okay.
And that is about the alcohol and the drug use that folks are talking about. My particular situation, my loved one did alcohol and drugs in his teen years, and a lot of people do. And what I believe more people are finding is that drugs and alcohol are used to self-medicate symptoms of bipolar or of schizophrenia or of you know, whatever it is, right? Depression. Because it's something that's socially acceptable in that age group.
Absolutely.
To do, right? So the on the marijuana issue, I just want to stress that what I've understood from someone, Julie Fast, who is on the West Coast, but she's written 4 books on bipolar. She has bipolar, well, actually she has schizoaffective. She's finally been diagnosed as schizoaffective now, but she's written books and she is a coach for parents of people who have loved ones with bipolar.
What is her name?
Julie, Julie, Fast, Fast.
I think I've heard of her, but thank you.
Yeah, and she's spoken at NAMI convention. She's on the I think the World something mental health or something. Anyway, she's very, very, she's excellent. That's all I can say.
Okay.
And she's been researching the marijuana issue for years because she keeps telling me, she says, the marijuana that you guys smoked in the 60s is not the marijuana that's on the street now. And right. And what we need to be doing is encouraging and lobbying to have the THC content of all marijuana products labeled clearly so that people know what THC content they're getting, because the THC is what triggers psychosis and all kinds of other things that's going on. It's not it. That's why the CBD oil, they say, is calming, right? And it's kind of like a sedative, but it's the THC that sends them off and has triggered and will trigger bipolar and other things.
Well, and that's the thing. I would say within the last 10 years, I have seen more symptoms of psychosis with marijuana or marijuana type products. A lot of the products that are like the candies, like the gummies or like the baked goods, I've seen, you know, people coming in and saying, oh, I just took a marijuana gummy and, you know, I haven't felt the same, you know, since this. And, you know, I do think that when you're adding a mind altering substance to a situation, that can trigger anything, you know. And as I said, you know, some of these young adults might not even have known that there could have been, you know, mental health symptoms, or there could have been, you know, genetic mental health, you know, in the background of their family that maybe they didn't even know. As you said, it could have been generations, or environmental stuff could be a stressor that they didn't even realize. And boom, here we are, someone's sitting in front of me and they're basically presenting with psychotic symptoms, and they're saying they've never experienced this before, and all they did was use a mind altering substance. So it's very scary, because again, some of these things that are on the street, they're laced with other drugs or chemicals that we don't even know. And, you know, that's the scary part. And also going back to self-medicating, I don't think a lot of people want to become dependent on substances. I do think that, you know, it does help hide symptoms. It does help manage symptoms. And it just also becomes, you know, part of a day-to-day life and day-to-day functioning. And so, you know, you can see the dual diagnosis happening often. You know, someone might have depression and then they might have alcohol abuse. And the interesting part is alcohol actually is a depressant. So it works, right? But yeah, there's a lot of times that you're going to see the dual diagnosis. So it's the mental health issue and the substance abuse, and they're working together. And, you know, we have to treat them both at the same time, because you're not going to start with one or the other. You work at both. And that's what a lot of the substance abuse facilities have been doing, which is great. You know, they are utilizing both components, because someone who's been using for an extended amount of time, once they're breaking away the layers of the abuse, they're recognizing, oh, there's been this mental health thing, you know, even something so simple as anxiety, social anxiety, someone who is, you know, I'm going to talk about anxiety in a minute, but someone who really fears being in a social setting, maybe having a couple drinks might make that social setting a little bit easier, or smoking marijuana before might make that social setting a little bit easier. So then you become dependent sometimes at, you know, you don't want to go into a setting without having your aid, right? Having that substance to help you. So you see this happening often, unfortunately.
Right.
Did anyone have any other questions about bipolar, schizophrenia, schizoaffective disorder, depression? Because I feel like the four of them can sometimes intertwine. So it's good to like have them kind of discussed in order and together in a way.
So when you say the laughing, like they don't laugh, they sit when you think something's funny and they don't think it. So is that cool? That's the bipolar? Is that?
No, that the reduced feelings of pleasure, is that what we
Yeah, right.
That was a negative symptom of schizophrenia, which you could also experience with the schizoaffective disorder if you're experiencing, you know, those type of symptoms. You know, but that could also, not being able to laugh or not being able to enjoy things, that can also be with depression. You can see that, you know, just not being present. The depression can be thought blocking. It can be distracting. It can be something that, you know, people don't even realize is interacting in their day-to-day stuff, and they're not able to just have normal conversation because they're distracted and the negative thoughts of the depression is overpowering.
Okay. Thank you.
Lynn, I just read what you said. So that that could be Asperger's. I mean, there are so many different, you know, things that people are experiencing that, yeah, sometimes someone might not just be experiencing mental health issues. They might be experiencing another, you know, maybe intellectual disability that could be affecting too. As you know, sometimes we also see the co-occurring on that end as well. Someone might have an intellectual disability and a mental health issue. So, and that's hard too, because, well, nowadays, I don't think it's as hard, because I think schools are a lot more aware and observing kids differently than when I was in school, and even 50 years ago. You know, I think a lot of people, unfortunately, were not diagnosed, and, you know, back in the day were slipped through the cracks and they passed them to the next grade and nothing was done. So, you know, you might find some adults with intellectual disabilities that never were diagnosed and aren't receiving DDD services, which is a shame, because they could have benefited from those type of services in addition to the other services that they could get. I can't read. Oh, that's good to know. But yeah, so any questions about that? No. I guess we can move on to anxiety and anxiety disorders. So what I always say is, I feel like everyone experiences some sort of anxiety at some point in their life. And there's different levels, right? There's different levels. There's anxiety that can be crippling and can be something that, you know, is with you forever. There's also situations that might cause you to feel anxious, but within time, you're able to move forward, right? Generalized anxiety disorder, it's like when it's a chronic disorder. So it is something that can affect you forever. And it's exaggerated worrying about everyday life, and it can consume hours of your day and make it hard to concentrate, make it hard to finish your routine or daily task. And it can be exhausting. And some of the symptoms of anxiety that people don't even realize are present are there's emotional and then there's physical. So some of the emotional symptoms are, feeling on edge, feeling tense, jumpy, not able to sit down, unable to relax, restless, irritability. Again, irritability. We've been hearing that a lot in a lot of these diagnoses. Anticipating the worst and being watchful for signs of danger. And, sometimes with anxiety, it could lead to paranoia. Anxiety can get so bad and crippling that it could become paranoia. And it's a matter of figuring out what is going on. What are we doing? Like, what is this anxiety something that's been forever? Is there a trigger? Is something increasing it? Did something happen? There's also something called hypervigilance, which is increased alertness. So maybe you're walking down the street and you are constantly looking around because you're anxious. Maybe you're walking in a dark area and you're anxious, but someone who's experiencing anxiety all the time might feel that on edge feeling all the time. Inability to set aside a worry and these racing thoughts, like the hamster that's on the wheel and it's just going and going and going, and your thoughts are going and you're unable to control them and slow them down. Difficulty shutting your mind off, not being able to find that comfort and that ease. Anxiety can be very draining. It could be very exhausting, which then leads me to the physical symptoms. Some people get heart palpitations. Some people get shortness of breath, which, can lead to panic, and people are unable to calm themselves. You'll hear sometimes people saying, like, I was doing deep breathing, because they need to so the deep breathing technique, it slows down the brain. It also slows down the breathing so that you're not, fighting yourself to get the breath. Upset stomach is a common one that a lot of people don't recognize. Some people might have that pit in their stomach, that or that nerve. Maybe they call you, back in the day, it used to be referred to as nervous stomach, right? Maybe you're feeling nauseous. Maybe you are throwing up. Maybe you're having upset stomach and having going to the bathroom. Some people have diarrhea. Some people can't eat. They are just, so nervous they can't eat. Some people experiencing sweating, tremors, twitches, headaches, fatigue, insomnia. And sometimes also people might have frequent urination, that nervousness that they have to constantly, they just keep going to the bathroom because they can't feel that sense of ease. But anxiety there's so many different anxiety disorders. So before I move forward, do we have any questions about that right now?
Does it feel like your heart's coming out of your chest sometimes?
Oh,
I went
absolutely.
to the heart doctor because I actually thought I was having a heart attack.
I was
Not
just
a heart attack, but I didn't
Yeah.
know. I couldn't stop the pain.
Mm-hmm. And sometimes a panic attack can mimic a heart attack. And I will never be the person that says don't go to the hospital, because you don't know, right?
Right.
If you have never had a panic attack and you've never had a heart attack, it is not your job to make that decision. I would go to the hospital, and a lot of times doctors will rule out all medical. And then once they've ruled it out, they can say, all right, well, looks like this was a panic attack.
Right.
And they'll ask, what was going on before this happened? And the reason they do that is they're trying to figure out what the triggers are. What caused you to have the panic attack? Or what caused that anxiety attack? And the hard part is sometimes if someone is experiencing them that frequently, nothing might cause it. Sometimes they come out of nowhere.
Almost every other day I feel like something's going on. Like my
Mhm.
heart's just like going crazy.
Mm-hmm.
But
And there's panic attacks. that can be a symptom of anxiety, but then there's also panic disorders, and panic attacks happen with them. And it's that sudden feeling of terror, something striking repeatedly and without warning. And again, you often mistaken it for a heart attack because it can cause powerful physical symptoms, including chest pain, heart palpitations, dizziness, shortness of breath, stomach upset. So yeah, it's scary because even as, you know, women, they're telling you all the time in the news that, oh, women who are having heart issues might have stomach issues. So it's like, okay, if you're having a panic attack and you're having these heart palpitations, chest pain, and stomach issues, then it's like, well, which one is it? And again, not your decision to make unless you are really certain, but it doesn't hurt to seek medical treatment if these are happening to you or someone you love and know, because you'd rather be safe, you know,
Right.
than worry. But a lot of people who are experiencing panic avoid having attacks because it's very uncomfortable. It's very scary. It's traumatizing, I'm sure, sometimes. And, you know, some people will stay isolated. They won't go to social situations. They'll avoid going to specific places. Some people, you know, say, for example, if you had a panic attack when you were driving over the George Washington Bridge because maybe you have a fear of heights. Some people might avoid doing that, right? They might do everything in their, you know, life to avoid having to go over a bridge because they don't want to have that feeling ever again. So, you know, a lot of the panic disorder stuff is medication, you know, to help treat that, but also to fight through that fear rather than avoid it, push through it, because there might be other triggers that happen. And then if you just continue to avoid and isolate, then the isolation doesn't help either.
Yeah.
And, you know, that leads me to phobias. I think everyone tries to avoid certain things or situations that make them feel uncomfortable or fearful. For example, not everyone would feel comfortable doing what I'm doing tonight, right? Some people just fear talking in public. And I mean, we're on Zoom, which is nice, right? But some people would fear having to present and have to talk because maybe they're worried that they're going to look stupid or embarrass themselves, or, you know, and these are fears that people actually have. They're real general fears. And, you know, again, maybe they would avoid doing public speaking. They would avoid going to social situations. They would avoid a job where they would have to do with public speaking because they generally fear having that feeling of embarrassment or that they're not going to be able to do it. And, you know, to avoid this, it can again be very isolating too, or they might not be able to experience things. Someone might not get a job because they're so fearful of doing something. You know what I mean? And again, that goes kind of to the social disorder. You know, social anxiety is, again, more fear, and it's driven by irrational worries about social humiliation, you know, saying something stupid, doing something stupid. I've had people tell me, like, I just don't know how to start a conversation. What if I say something stupid? And I'm like, okay. So what I've done is I've role played. Let's have a conversation. How would you, you know, go in a social situation? How would you start the conversation? Some people generally feel more comfortable with another person leading the conversation, you know, asking the questions and they answer because maybe, you know, they don't know how to go to the next topic. But social situations, some people fear being in large crowds. Some people fear having to go out and plan how they're going to get there, how they're going to get home, the fear of being stranded somewhere socially. So then maybe they just don't go. And it's not shyness. You know, there's shyness and then there's social anxiety disorder. They're different because someone who's shy isn't fearing that social engagement, where, you know, that's where the difference lies. But in social situations, panic attacks can happen as well. So, you know, there's a lot of crossover with the anxiety disorders and their symptoms. But, going back to generalized anxiety, that is, the one that consumes the person's day-to-day functioning. And you might find someone who, fears leaving their home, has agoraphobia. And, separation anxiety is also another, anxiety disorder. But then there's also the substance abuse or medication-induced anxiety. And that can do with intoxication or withdrawal. And that's a whole different thing. And again, anxiety, families with a higher than average number of members experiencing anxiety, studies show support that the evidence that anxiety disorders will run in the family. So it could be genetic, but then again, stress. We live in a very stressful world. We've dealt with a pandemic for the past year. So I'm sure a lot of people, they talk about it all the time on the news. People are saying that their anxiety levels have increased, or people are noticing they have anxiety and they never had anxiety. Things that are stressful can trigger anxiety. So again, I think everyone probably will experience it at some point. It's just a matter of how long does it last? Does it become something that takes over and, affects your life longer than maybe a situational setting where you move forward from the situation and it's fine?
Yeah, it's crazy. I felt that today when we were going on, I felt like a little anxiety because I was going to be asking questions, and I'm like, I don't know if I'm saying the right thing. Is that how you ask it? I'm like, just ask it, just say it.
Just ask it.
Say it.
Yeah. And this is a safe environment, and that's something to remind yourself too. No one's judging, and I don't have all the answers. I only know what I know from, education and from experience working in the field. And I think, one benefit with mental health issues and, just treatment and diagnosis, we're learning more and more, and we're evolving. There's different medications that are helping different types of diagnosis. There's old school medications that, maybe aren't as used as much, but are used for other things. So, we're always evolving. There's always new things. There's new treatments. The one benefit is mental health treatment and therapy is a lot more popular and, common than it ever was, which is great. People talk about the therapists more now than they would have 50 years ago. 50 years ago, it was taboo. So it's great that it's more open. Any questions about anxiety and anxiety disorders? Yeah.
You done?
Yeah, I don't, if there's any other, I usually touch on the ones that are the most common. If there's any that anyone had questions about, we could always discuss. But those are the ones that you're gonna hear most frequent about, I think. And I think it's important to understand them more, because I feel like society has given this view of certain disorders that's not really true, and label people a certain way that doesn't make sense. And then it kind of gives a mental health diagnosis a bad name, which it shouldn't, because people can function. It shouldn't define you. I try to say that to, clients too. It shouldn't define you. It's just, something you have to manage, like your high blood pressure.
No, I'm sorry. Go ahead.
I know you went over it, but I'm still not clear on the difference between schizophrenia and schizoaffective disorder.
Okay. So schizophrenia, you're not going to see the mood disorders. So you're not going to see the bipolar disorders or the depression. You're just going to see the schizophrenia and the, clear symptoms of psychosis. So the hallucinations, the delusions, the positive and negative and cognitive symptoms, which is like the flat affect, the reduced feelings of pleasure in life, difficulty with daily functioning sometimes. Some people you might see difficulty completing their activities of daily living, showering, bathing, doing their laundry. Maybe they're not cooking as often, trouble focusing or paying attention, maybe sometimes difficulty understanding. There's a great training that I was part of one day where they put headphones on us, and it was just a client actually was recorded their hallucinations, their auditory hallucinations, and like what they experienced. And they had us have our headphones on and then try to talk to someone. And you're hearing these voices, which a lot of people do experience. So the idea that someone might appear distracted because they might not be hearing you, because there's other stuff going on in their brain, they might not be able to comprehend what you're saying. So those are the psychotic symptoms that schizophrenia has. Whereas schizoaffective disorder, you might have those psychotic symptoms, but also a mood disorder, whether it's bipolar traits or depression.
But there's no medical way to diagnose someone's brain to say that they have schizophrenia, correct? In other words, no EKG or EEG or whatever it is.
Yeah. Oh, like a brain scan?
Yeah.
I don't think I've never heard of a doctor diagnosing brain scan wise. Like I know like with Alzheimer's disorder, they don't know until someone has passed away when they can do the brain scan, right? That's what they always say. So they're like, yeah, it looks like the symptoms. I've never heard of a brain scan with schizophrenia.
We've had a couple of families who have paid a lot of money to go to very fancy hospitals in the city to get brain scanning and brain mapping done. And there's an actual, I forgot, it's some crazy name, but it is probably fairly close to happening. I don't think it's there yet.
That would be awesome. That would
Yeah, that's what I mean. Can you see anything? Can you like what's going on with the brain? Like what happened? What's a dopamine, not dopamine, or what's it called? There's not a.
Yeah.
That's the whole thing about all the mental health diagnoses, Barbara, is that it's an intangible illness, right? That's the truth of it. You can't look at somebody's blood work and say they're schizophrenic.
Right. Exactly.
And that's the reason too why there's all this level of interpretation depending on the prescriber or the person who's doing the diagnosis. Because and that's why the diagnosis has changed all the time. Because somebody's going to go and to their hospitalization and be seen by a psychiatrist, and they're going to be like, well, you know what, you seem very much like you're schizophrenic today. But then another time they might go in and they're presenting and you're going to see the mania part. So then they'll be bipolar. And ultimately, what do you figure out? It's like most likely schizoaffective disorder. So a lot
That's why it's so confusing.
It's confusing.
Yeah.
But that's why Tara said too in the beginning, the diagnosis don't matter so much. And we like to think of it, it's almost like a spectrum in a way now too, because at a certain point in somebody's life, they could be moving up and down the spectrum of, you have major depression on one side, you have bipolar, you have schizoaffective, and then you have schizophrenia. And at any point in somebody's life, they could be moving along that spectrum.
And 50, 60 years ago, we didn't have all these specifications. A lot of people were thrown into state hospitals and diagnosed with schizophrenia, and that was it. And then, and I've read stories and research, and it's like, well, Bob, I'm just making up a name, Bob was diagnosed with schizophrenia, but he was able to hold down 2 jobs and he was able to get 2 pensions. And I'm like, well, that's interesting. Maybe he was, but his mood was a roller coaster and he was, very manic and this. And I'm like, well, he probably was more bipolar and it just wasn't the right diagnosing. And, a lot of people were just labeled, and we also had so many different medications. And, as mental health has evolved, our diagnostic criteria has changed too. We have, we had diagnoses in there that now would be a disgrace, you know, because it's just not a diagnosis, but this was just different times. And sometimes the symptoms look different on a different day, as Jenna said, you know, and so someone might have been diagnosed with schizophrenia when they were 25, but then as they grew and their hormones changed and their brain was more developed, because they're finding out that the brain isn't fully developed now until like your mid-20s, they're saying things changed, symptoms changed, life changed. So you know, I think the most important thing is recognizing working in the moment and treating what the client is presenting with in the moment. And, you know, if the medication doesn't work anymore, then you're revisiting. And that's why a lot of doctors like to see their clients every 1 to 3 months, every 6 months, just because they want to see how that person is doing.
And what about the dopamine? What does that mean? The dopamine in the brain? I'm probably not saying it right.
The dopamine.
Yeah.
So are you referring like to like depression?
Yeah, like or the bipolar or whatever.
So they do say, you know, with depression, with the bipolar, it is a chemical imbalance, right? So you know, you might not be, so someone who's experiencing depression might not be releasing enough happiness, enough of the dopamine. Dopamine is the happiness. So some people get happy with food. Some people get happy with exercise. Exercise is the big dopamine release, right? So some people might not be getting enough of it. And so then sometimes the mood is stabilized with these mood stabilizers, with the antidepressants.
Oh, okay. Okay. That's what I was wondering too.
But yeah, you know, these are chemical imbalances. But again, it would be nice if we could just do blood work and say, okay.
That's right.
This is the chemical imbalance. But you know, some good information, and I don't know if anyone is aware of this, they're doing research, blood work now. A lot of insurances are covering it more, where they can test you and see what medication your body will digest better. So say you're someone who's suffering from depression, they will do a panel and test the antidepressants and mood stabilizers, and it can see what medication will digest better in your body, which is
good to know.
Yeah, it's kind of cool.
Test.
What?
It's a genetic swab test.
Yeah.
That's what.
So
it's like getting a DNA test done, Barbara. They swab your mouth.
Yeah.
And then
I think my son had that. He did have that.
It's becoming more popular. Even at Newbridge is starting to do it more.
Mm-hmm.
So does that mean that it digests better or it's more effective for the person?
Both. When I say digest better, I'm sorry, will be more effective. So your body will be able to handle it, and it will see what is more effective and what is not. Yeah. I've had clients get this swab and say a medication they were on is like the one that their body is least effective.
Mm-hmm.
Which
categorize all the medications into 3 different categories. Yeah. The ones that are going to be least effective, the ones that are going to be somewhat effective, and then the ones that are going to be most effective. So it's a tool for a psychiatrist to use now and go off. Obviously, you start with the ones you would think would be most effective, but they have terrible side effects. That's part of the problem.
Mm-hmm. Right.
So it's really just more of a roadmap for a psychiatrist to use in the beginning of prescribing a medication.
Yeah. And insurance companies, I think, are covering it more and more, which is great. Yeah. When it first came out, it was like, nope. But now insurance companies are covering it. So it is a great roadmap for doctors to see where they can start. Because sometimes that's hard. And that's a lot of a reason why people don't want to continue medications. Oh, I've taken so many. I've had so many side effects. Nothing worked. Yeah. You know, it's unfortunately something that you hear it a lot. So
it discourages people.
Yep. Absolutely. So again, you know, mental health treatment and medication is definitely taking positive steps forward. I've taken some time, but there are positive things happening.
I have one other question, just out of curiosity. You mentioned that women are prone more to bipolar disorder. Is it because either it's hormonal, or because women are more likely to come forward with the the conditions, then men, you know, they're more likely to bring them to someone's attention than men.
Did I say, I think it was depression that women were.
Oh, depression, you're correct.
Yeah,
Yes.
women were likely to experience it. You know, I don't know that answer. I don't know why women are more likely. I mean, it could be that women are more likely to come forward and get the help. It could be, you know, I'm sure there's some theory. I don't know that answer.
Okay, it was just a curious question.
What? Hormonal?
Hormonal. I mean, it's the same thing when you see it. Sometimes it's harder for a woman to get the right medications for them because every once a month, you know, things change in a woman's body that is, you know, might not work with the medication that she's on anymore. So, you know, sometimes it's harder for women to stabilize. And then you see that too later for a woman who is diagnosed with a major mental illness, bipolar disorder, schizophrenia, major depression. Later in life, you see men can sometimes get better. Women tend to get worse at some point later in life, and then they get better because of menopause.
I was just going to say, then you have the hormonal changes when you get older. But again, you know, with women, there's also medical stuff that can trigger the depression too. You know, the hormonal issues with, you know, your body. What? Childbirth, right? There's childbirth, but there's also just like certain hormonal stuff that women go through where their hormones are not always balanced. So then they might notice some mood changes. And then this might also happen not just once a month, and then it can increase and get worse. So, you know, I also think women probably are more open to probably getting the help. But again,
I think they are too. I think they say it more too. I think when I went through my changes, I used to be so strong. And then once I went through my changes, I'm not that person anymore. I don't know what happened. Like everything bothers me. So I don't know, but.
Well, I even noticed I used to laugh when my mother would cry watching, you know, romantic movies. And now I find myself tearing up. Like, what happened? So, you know,
I know. Things change.
You know, and again, going back to the hormones, women, we have hormones, and, you know, men have their own changes too. But I think our hormones do affect a lot of our day-to-day stuff, and especially our emotions and our mood.
I think because we take on so much, we don't realize how much we take on until it breaks you.
A lot of women are, you know, caregivers by, it just happens. It becomes their thing. So, you know, there's a lot we also don't know about mental illness. And I think, you know, with time, we're going to probably learn more. And unfortunately, it's not such a clear science like cardiac issues. Okay, here's cardiac issues. This is what you need to do. And everyone will, and you'll be better. There's a lot of approaches, which is good and bad. You know, some people might just want that one approach, but it's good that there are so many options for people so that maybe there's, you know, help for everyone.
Right. This was very interesting tonight. Thank you. It was very interesting.
Yes, very informative and easy to understand.
You're welcome.
You want to say anything?
Me?
Yes.
Well, there's so many things I want to say, but this was excellent. Thank you so much.
Oh, you're welcome.
One of the things, you know, we can talk about all the different types of you know, problems and issues, but behavioral comes up a lot. And I know that could take us on another hour or two down. But I have a situation with my son that is diagnosed, and I get hit a lot of times with behavioral. How can we change our behavior in the home and make a difference? And it's so hard to do, to live in the same home with somebody who has so many issues. And behavioral, how do you start changing and doing things differently when you have somebody? But I think that's probably a discussion for another time.
I'll answer that question very quickly.
Okay.
Have you read the book I'm Not Sick, I Don't Need Help by Xavier Amador?
No.
So write this down. I'm Not Sick, I Don't Need Help is the name of the book. The author is Xavier Amador, Amador. And he is a very well-known psychiatrist in the city who has a schizophrenic brother, or had, he actually passed away. And he outlines a very, very helpful communication technique in dealing with your mentally ill loved one. It's called LEAP. And it's the gist of it is basically when your loved one is telling you the sky is purple, you don't come at them in a combative way. You say, I understand that you see it as purple, but to me the sky is blue. So let's come to general, understanding of the situation. But this has been the Bible for all the families that we work with. They love this book. You can look at Behavior Ambulance on YouTube. He's very, very soothing, and he's very good at this communication stuff.
I just took out the book Codependent No More.
Okay.
So trying to get through that one. But I will definitely look into that one. Thank you, Jenna.
You're welcome.
Yeah.
What was the name, Jenna? What was the name again? What?
I'm not sick. I don't need help.
Okay.
That book has been the discussion since I have done these talks. It's always been the book that everyone has referred to and has suggested. So
it's very hard. You're not going to be able to change your loved one's behavior, but you can change how you react to it.
Right.
Exactly.
I think that's how the way you have to go.
Yep.
Because when they scream in it.
At the beginning, to learn about the resources, to learn about the disorders, the education is power. So if you come from a place of power and education, it will be very helpful to you.
So I feel out of control and powerless, and that's bad.
So then you have
Bad way
to
to live.
focus on the things that you do have control over, and that is how you react to the situation, your education about it, like we just said. That's the things that you do have control over.
Thank you. It was very interesting tonight.
Before we wrap up, I just want to let everybody know that all the disorders that Tara talked about tonight, you can go to NAMI.org. And there's a little section called About Mental Illness. Click on that, and then under that it says mental health conditions, and it literally lists all the mental health disorders and all the little fun facts that Tara made out tonight.
And there's definitely going to be probably more information there that I might not have discussed or passed up, or might have made a little bit more confusing than that wrote. But, I gave you the gist of kind of what's going on.
The cliff notes.
Yeah. And you know what? It also, again, everyone experiences these symptoms and these diagnoses differently. So that's something to always remember. It's not so, clear cut and textbook. And, meeting them where they're at is the most important thing.
Yeah, it is. It's hard. It's very hard. But
Well, if I can just mention one thing. Some years ago, we brought a program to our church from NAMI, the family to family education. And there's an exercise, there were other exercises, but the one exercise that stands out for me about how to kind of develop our own empathy for someone is that there was a group where everyone had to be trying to perform a task. But in the background, there were a bunch of us saying all different things and talking and singing and doing, and so that we could understand what it's like to be a person with an illness and have all those distractions in your head all the time, whether they're voices coming at you, seeing things that aren't there, and so on. So if anyone is interested, I think NAMI is still giving that program, if I'm not mistaken, right, Jenna?
Yeah, you can go to NAMI Greater Bergen and find out. I don't know where the family to family, it has to be through Zoom now, so there's probably more availability. That would be on the NAMI Greater Bergen website.
I think it's wonderful for parents. It certainly helped me. So
I have to say, Rita, I took the family to family course at Newbridge, and that one incident that you just spoke about, I experienced myself. And I was just talking the other day and telling somebody else about that. What it was like, people came in and you have to listen and try to write down something that somebody's talking to you about, and you've got all these distractions. That hit home. It was amazing. amazing experience.
I don't know if anybody's gone on a website where you have to type in some letters. And if you can't read them, sometimes they're hard to read, you can listen to them. And they do the same thing. They give you the letter, but there's so much noise in the background.
Yeah.
And you don't have the disability and you're trying to pay attention
Yeah.
and you cannot do it. So I can only imagine, I haven't gone through those, but I can only imagine how difficult it is for somebody with one of these conditions to try and manage their life.
Right.
Try to be in their shoes.
Are we all done then?
Yeah,
we're
thank
good?
you. Yep,
Thank
thank
you
you,
again.
Jenna.
Both of you,
Thank
Jenna,
you,
as well.
Tara.
You're
Excellent
welcome.
program. Thank you.
Thank you.